Hi dear colleagues, I'm Dr. Samuel Davani, attending professor of cardiovascular surgery and dean of faculty of heart lung transplantation of Iran University of Medical Sciences and Healthcare Services. Today I'm going to, contemplate or introduce a very interesting case with a lot of intricacies with you regarding the pulmonary thromboembolism. The patient had spontaneous, unprovoked venous thrombosis, diagnosed with lower extremity ultrasound, and confirmed with the color Doppler wave either. Came into the ED of the CLHD with complaint of shortness of breath, and according to the presence of the DVT in the patient, despite being on blood thinners, including aspirin as well as apixaban, our primary suspicious was, to have a massive pulmonary thromboembolism. So the CTA angiography of pulmonary or CT pulmonary angiogram done for the patient, CTPA, and the presence of the left complete total occlusion of the pulmonary artery by massive pulmonary thromboembolism, confirmed. We was making decision to put the patient on, blood thinners, including the heparin administration via the infusion, or just proceeding with the surgery or just intervention. The patient hemodynamic was stable, but actually the RVOT clots protruded into the left pulmonary trunk, as you can see within the imaging modalities, and the patient hemodynamic, as well as the RV function became deteriorated. On emergency basis, it was my, honor to take the patient into the angiography and to perform. It was my first time to performing the pulmonary basket thrombectomy from the femoral axis, and I performed a confirmation diet study for the patient. As you can see, I omitted the name of the patient, and at the right side up the corner you can see my name as a performing procedure, the physician of the patient, and I was really thrilled with the results. And actually after it, we wanted to check regarding the possibilities of the patient pulmonary thromboembolism, and when we wanted to put a IDC or fully catheter indwelling urine catheter for the patient, we encountered hard passing a catheter because the patient felt TOV or trial avoiding post angiographic thrombectomy, and actually the PSA level of patient was really high. At the same time, the CRP level, and the patient was in the context of the prosthetic meds. Really appreciate for your attention, and I really appreciate if you give me comments regarding the procedure that I performed, because it was my just second, and according to angiography, because used to be cardiovascular surgeon, not angiographic surgeon, I have a limited experience in that context. I really appreciate if you give me your uh, feedbacks. Bye.